Okay, so today's presentation will be on complex congenital anomalies. The presentation will cover three different types of the anomalies. First one being the TOF, second one being TGA, third one being the HLHS, and I'll go into more detail what those stand for and what they mean. So the first one is TOF, as mentioned. And TOF stands for the tetra of Fallot. And TOF is the most common cyanotic lesion in the adult population, and we will go into a little bit more about that later. And for definition, it is characterized by a combination of four defects, also known as the four or tetra defects. So these four defects are as follow: pulmonary stenosis, a large overriding aorta, which is a overriding aorta, which is a heart condition in which the patient or child is born in when the aorta is in the wrong place. This can vary, meaning sometimes it sits near the RV side and sometimes it can be closer to the LV side. The third defect is RVH. That basically means the myocardium, the RV is getting thicker, and within an X-ray, the image will show a boot-like shape of the heart on a scan. So the fourth defect is going to be the malalignment of the ventricle septal defect. Now, this one is a little bit more tricky. This is a defect that allows a gap between the ventricle that allows the shunting of blood between them due to the possibility of PS, the pulmonic stenosis, which is a type of RVOTO. Once again, that stands for right ventricular outflow tract obstruction. This could contribute to the right side pressure ending up being the higher pressure and will have more deoxygenated blood shunt from the right to the left side. So the critical feature of these four defects is the degree in which they are an obstruction to the RVOT. With less obstruction, such as uh, with less obstruction on the RVOT, the left to right shunt will have oxygenated blood that will have a chance to get into the pulmonary circulation. But with more obstruction of the RVOT, we'll have a right to left shunt, and that will result in poor oxygenated blood shunting from the right to left, and more than the same blood that is going into the systemic circulation. And that is important because if we remember, the systemic circulation is blood going to the rest of our body. And if we have, poorly oxygenated blood going to the rest of our body, that ultimately can result in the less oxygenated blood getting there in the tissue and not getting to the tissue, and that will cause our body to eventually um, have the less oxygenated blood that drops below 80%, and it will ultimately cause the patient's skin to become bluish purple, which is known as cyanosis. So, babies with cyanosis usually have that bluish purple skin on the fingertips, and lips, and they typically experience exercise intolerance while squatting, with squatting episodes and TET spells. And TET spells are episodes of faintness and cyanosis. So the severity of symptoms usually depends on three things: the degree of the pulmonic stenosis, the position of the aorta, and the size of the VSD. Now, diagnosis is usually done with echo and can be done prenatally. With treatment, we have cardiac repair surgery, which will attempt to fix the septal defects and RVOTO. Next up, we have TGA, which is the transposition of the great arteries. And TGA is a congenital heart defect where the two main arteries, the aorta and the pulmonary arteries, are switched in position. And there are two types of those, the TGA. The first one is going to be your dextro loop, also known as dextro TGA, DTGA, or simple TGA. But I may just refer to as dextro for short. So, a dextral loop occurs during the development, causing the great arteries to be transposed. An explanation of dextral would be that the aorta arises from the anterior ventricle, and the pulmonary artery arises from the posterior ventricle. Next, the systemic flow returns to the RA, then goes through the RV into the aorta, and then the body back to the RA again. And for the pulmonary venous flow, the blood returns to the LA, then to the LV, and into the pulmonary artery, into finally the lungs and into the LA again. So the takeaway is that this creates two independent parallel circuits instead of one cohesive unit. This means the patient with dextra TGA will depend on the intermixing of two circuits through the PFA and PDA and VSD. So you're going to be depending on those to be alive. And when those shunts they close, sudden death occurs because the body doesn't receive the oxygenated blood. So these shunts they must be maintained and kept open with prostaglandin, which are hormones-like substance that affects several bodily functions. And the signs and symptoms depends on the degree of the intermixing of blood. The patient will show either minimal cyanosis or intense blue coloring. And additionally, additional anomalies that are often present as well with dextral looping is VSDs, ASDs, PS, and right-sided aortic arch. So, unfortunately, kids who have DTGA, they do very poorly, and it is very rare for them to live past 2 months. And the next type of TGA is levo TGA, also known as LTGA or corrected TGA. In LTGA, the ventricles are transposed. So the anatomical RV is displaced posterior and leftward, becoming the arterial ventricle, and the anatomical LV is displaced rightward, becoming the venous ventricle. The flow works like this. The pulmonary venous flow returns to the LA, then the anatomical RV and onwards to the aorta, to the body, and into the systemic flow, back into the RA, into the anatomical left ventricle, into the pulmonary artery, into the lungs, and back into the LA again. Now, despite the displacement of the ventricle, the pulmonary artery still rises from the venous ventricle, and the aorta still arises from the arterial ventricle. If no other defects are present, the heart can usually still maintain normal function for about 15 to 20 years, but eventually the systemic ventricles will fail. And if there are other defects such as tricuspid regurgitation, about 20 to 30% of these patients will die within the first year due to congestive heart failure, unless they're treated with palliative surgery. So the treatment for TGA is it's conventional repair and anatomical repair, and I'll go into more detail. So with conventional repair, this usually means you fix associated defects, but you leave the RV pumping to the body. Now, with anatomical repair, also known as the double switch, it's an option in which the objective is to switch the atrials and also the arterial um, switch to allow the RV to pump out to the pulmonary artery still. And there is also another procedure which it seeks to have a tricuspid valve replacement, um, and that's been seen to be advocated in the recent years as it has shown some symptomatic improvements. Okay, and the last one is going to be our HLHS, which stands for hypoplastic left heart syndrome. And the left heart is, and HLHS is when the left heart is undeveloped due to a restriction of the left ventricle inflow or outflow due to one of the following reasons. It can be mitral atresia, which happens to deal with inflow reduction when the mitral valve is too small or completely closed. Second, it can be due to aortic atresia, which is outflow reduction. and that happens to do with the aortic valve being too small or atretic. Third, it can be due to hypoplasia of the aorta, which happens to do with outflow reduction, and the aorta is usually underdeveloped or too small. And all those three is basically to say um, we don't have full functioning LV functions because it didn't develop, and we don't get the blood pumping to the rest of our body. And usually ASD is used to sustain life at this point. So the burden of both the volume and pressure that is placed on the right heart, is placed on the right heart, I meant, because it is working to assist the underdeveloped left heart while the fetus is still developing. So that means we will be relying on the ductus arterioso and foramen ovale to assist with circulation. But unfortunately, soon after birth, the DA and FO closes, and the infant will start to experience, worsening symptoms because the left heart is so small that it's unable to pump blood once again to the rest of the body. And if left untreated, survival is going to be impossible. Now, diagnosis is made if aortic annular size is reduced, if LV is less than 10 millimeters, or if the mitral valve is distorted or absent. Now, thankfully, with advancing technologies, infants have not many, but a few options now to help. And the key really to treating this is early detection. It can be detected as early as 16 to 20 weeks into the pregnancy. But the hard part to accommodate for is the fact that most of these care must be done at critical care hospitals that are prepared to treat such intensive HLHS infants. So if they're able to get to one of these critical care hospital with the right conditions being met, um, prostaglandin once again is administered to maintain the shunts. And once a patient becomes stable, the surgical procedures can begin and be performed. And there are three major procedures in this specific order also, which the first being the Norwood procedure, the second one being the bidirectional Glenn shunt procedure, and the third one being the Fontan procedure. So with the Norwood procedure, the first stage, this is typically the first stage of the HLH treatment, and it's performed within the first few days of life. The aorta is reconstructed, and a shunt is placed to improve blood flows to the lung. The RV is then used to pump blood to both the lungs and the body. Now, second is once again the bidirectional Glenn shunt procedure, and this is the second stage. So this is typically performed when the infant is a few months old, usually around 4 to 6 months. And during this procedure, the SVC is connected directly to the pulmonary artery. This helps to divert oxygen, pour blood from the upper body directly to the lungs, and this allows for the bypassing of underdeveloped left side of the heart. Lastly, third, the Fontan procedure. This is third and final stage of surgical treatment for which typically is performed when the child is 2 to 4 years old, and during this procedure, the inferior vena cava is connected to the pulmonary artery, allowing for the oxygen poor blood from the lower body to bypass the heart and flow directly to the lungs for oxygenation. Now, although survival has improved drastically, HLHS is still a very complicated anomaly and is often associated with very, very poor survival rate. So, in conclusion, in ECHO, we play a pivotal role in the diagnosis, management, and monitoring of complex congenital anomalies of the heart. And so, as you've seen with the previous procedures, early detection is very important. And as cardiac sonographers, that's what we should seek to do and help play our role. Thank you.